Good evening. I'm James Ritchie, and I'd like to welcome you on behalf of BOFAS Scientific Committee to this latest edition of our Virtual Journal Club. Thank you for staying in on this wet, rainy autumnal night to join us. We have, as usual, two papers for presentation this evening. The first on profibular tibial fixation versus hindfoot nailing in unstable ankle fractures in those over the age of 60, and the second on a comparison of early motion and directed exercise after ankle fracture fixation. We have joining us tonight two senior authors. We have Ms. Carolyn Chadwick from Sheffield and Professor Ben Ollivere, both of whom I think are well known to the BOFAS audience. The format will be the same as usual. We will start with a presentation of the first paper. We'll then take our share reflection from Ms. Chadwick on the methodology of the paper, and then take questions from the virtual floor. Please do submit your questions through the Q&A channel. Then we'll move on to the second paper and following the same format. At the end, you do not need to do anything in order to obtain your certificates. A link should be sent to you automatically when you log out of the webinar. Failing that, you'll receive an email about it. I'd like, before we go any further, to thank, as always, my long-suffering co-chair, Nijil Vasukutty. This is potentially his last webinar as his term expires on the scientific committee, although he's standing for re-election. So, vote Nijil, and we have plenty more of these. Also, a big thank you to May Labidi of the IT committee, who is standing down after holding this together for a very long time. So May, thank you very much for all your hard work over the years. I'd also like to thank our two presenters, Claire Spolton-Deane and Ben Lau, who kindly prepared the presentations for us this evening. The first presentation is by Claire, and this is the pro-tibial fixation versus hindfoot nailing paper. Claire is currently an ST8 in the Peninsular Deanery, and I gather is due to start a fellowship in Newport shortly. So Claire, thank you very much for preparing your presentation. And Ben, if we can have that, let's continue without further ado.
Good evening. Thank you very much for the opportunity to present this paper looking at a comparison of fibular pro-tibia fixation versus hindfoot nailing for unstable fractures of the ankle in those older than 60 years. This was published in Foot and Ankle Specialist in 2021 by Blundell et al. Ankle fractures in the elderly represent a growing clinical challenge, with the optimal management of unstable patterns remaining a subject of ongoing debate. The aging population, coupled with comorbidities such as osteoporosis and frailty, complicates decision-making and post-operative recovery. A variety of operative techniques have been described, each with distinct advantages and limitations in this cohort. As such, determining the most effective and safe approach is a critical question with direct relevance to orthopedic trauma practice, particularly for surgeons managing complex injuries in older adults, as most of us will be. This study provided us with a clear aim, namely to compare the clinical outcomes of fibular pro-tibia fixation versus hindfoot intramedullary nailing in patients over 60 years old with unstable ankle fractures. Specifically, the authors sought to determine which technique offered better results in terms of revision surgery rates, complication profiles, hospital stay duration, and overall recovery, addressing a key question in the management of fragility fractures within the elderly population. This single-centre retrospective study was conducted over a 6-year period, during which electronic theatre records were screened to identify patients over 60 years of age who underwent operative management for unstable ankle fractures, using either hindfoot intramedullary nailing or fibular pro-tibia fixation. Of 1,417 ankle fracture cases reviewed, 68 met the inclusion criteria, 27 were treated with intramedullary nailing, and 41 with FPT. Radiographs and clinical notes were then subsequently examined to collect data on patient demographics, comorbidities, soft tissue condition, length of hospital stay, operative duration, complications, reoperations and outcomes. Retrospective FRAX scores and Charleston Comorbidity Index values were calculated to assess baseline risk. Clear exclusion criteria were applied. The choice of fixation method was made collaboratively by the treating surgeon and the on-call consultant based on the feasibility of lateral malleolar plating, soft tissue integrity, and surgeon preference. Implant selection was standardized, with a T2 ankle arthrodesis nails used for intramedullary nail and Stryker Variax distal lateral fibular plates for FPT. Procedures were performed by 16 surgeons, including 8 consultants who either operated or directly supervised all cases, each with experience in both techniques. Although no statistically significant difference was identified between the overall cohorts, several outcome measures favoured fibular pro-tibia fixation over intramedullary nailing. Reoperation rates were significantly higher in the nailing group, 12 versus 2 patients, and this was further assessed for confounding using binary multivariate analysis. Complications occurred in 56% of intramedullary nailing cases compared to 12% in the FPT group, achieving statistical significance, with non-union rates notably increased in those treated with intramedullary nailing. While a greater proportion of FPT patients returned to baseline mobility, this difference did not reach statistical significance. These findings suggest that despite comparable baseline characteristics, FPT may offer a more favourable clinical profile in appropriately selected patients. This study has several limitations inherent to its retrospective single-centre design, including potential selection bias and limited control over confounding variables. The relatively small sample size may also affect statistical power, and treatment allocation was influenced by surgeon preference, which introduces further bias. Additionally, functional outcomes were not assessed using validated scoring systems, limiting the ability to quantify recovery. However, all limitations were clearly acknowledged by the authors, and steps were taken during data analysis to mitigate their impact. Although fragility ankle fractures are frequently encountered in clinical practice, they remain under-researched compared to hip fractures, despite their significant impact on patient outcomes and healthcare resources. This study demonstrates that intramedullary nailing in patients over 60 is associated with longer hospital stays, higher complication and reoperation rates, and poorer functional outcomes when compared to pro-tibia fixation. Based on these findings, FPT appears to offer a more favourable treatment option, provided soft tissue conditions allow for a safe lateral fixation. In cases where soft tissues are compromised, intramedullary nailing does remain a viable alternative. However, given its elevated risk profile, careful patient selection and thorough consent are essential. Further research, ideally in the form of a prospective randomized control trial, is needed to validate these findings and guide best practice in this growing patient population, as highlighted by this important study.
Thank you very much, Claire, for that very succinct presentation. So in a moment, I'd like to invite Carolyn Chadwick, one of the senior authors on that paper, to reflect upon the work. I'm sure Carolyn is known to most of you. She's a stalwart of BOFAS and has indeed been a Sheffield lass through and through. She undertook her undergraduate training there, and I believe postgraduate as well. She did in fact venture across to sunny climes for a fellowship in Brisbane with Terry Saxby in Australia, but the draw of the flat caps, the Whippets and the Theakstons was far too much for her, and she returned to Yorkshire as a consultant, having been in Sheffield ever since. She's now in fact the senior foot and ankle consultant in the Sheffield Trauma Massive, Messrs Blundell and Davis having moved on to grander things. Carolyn has published very widely on foot and ankle surgery, particularly on trauma, and we're very grateful to have her sharing her thoughts with us this evening. So, Carolyn, without further ado, could you tell us a little bit about the trial, what made you do it, and what your feelings are about the study?
Thank you so much for the kind introduction, and thank you everyone for inviting me along tonight. And thank you for the presentation of the paper, which was very clear, and hopefully got some key points out of that. So in Sheffield, we have an enormous amount of trauma, and certainly since I started as a consultant back in 2012, we've had an increasing number of elderly ankle fractures. And in an ever-growing population of increasing comorbidity as well, this was becoming a lot of our workload. But with those elderly patients, getting back to some form of function was really important. And probably historically, the bailout for an elderly osteoporotic fracture was just stick a nail up and get them out of hospital. But that was the problem. They were staying in hospital beds for long times. Getting discharged was difficult, and their mobility levels were very low. And that's why we thought there must be a better way of treating these to get them out of bed, get them weight bearing early, and actually maintain some of their function. So obviously this was a retrospective study, which is certainly one of the limitations of the study, but we just had a feeling that patients who had rigid fixation that allowed them to get up and weight bear early was going to provide some improvement in terms of their outcome. So that's really the reasons why we did it. Obviously, as was mentioned, the numbers are small, but there was some statistical significance between the two, which we felt was relevant, that has changed our practice going forward, certainly. There's lots of downsides to both that we can talk about, but certainly the hindfoot nail used in many situations. One of my other previous now retired trauma colleagues, you may know Simon Royston, always used to call any form of nail the instrument of the devil. It has its uses, but picking your patients is obviously the careful thing. And certainly from an ankle fracture perspective, maintaining motion, preserving the other joints, but providing a stable, rigid fixation to get patients up and out of bed is really important. I think it was possibly touched on as well, just the reference to these are probably as significant as neck of femur fractures. And we all know the guidelines in terms of timing to surgery for these and getting patients back up and weight bearing straight away. And these fragility fractures or, where patients aren't mobile afterwards, they'll probably have significant morbidity and mortality, not dissimilar to those neck of femur fractures. So that's really the reasons why we thought it was an important thing to look at. Our results kind of validated what our sort of ideas were, and hopefully our results and statistics prove that in a chosen population, this would be our primary choice of surgical technique to deal with these difficult cohort of patients.
Carolyn, thank you very much for that. Just a reminder to everybody, if you'd like to submit questions, please do so through the Q&A channel. This is a friendly, traditional BOFAS meeting in which no question is too foolish, and I promise not to ridicule anybody, well, no more than it deserves. No, not really. A couple of other questions. So Carolyn, just to be clear with this, it was very much surgeon preference that decided which procedure was undertaken. Did you have a lot of wound problems with the lateral approach when you did decide to go for lateral approach fixation?
So sorry, I should have mentioned this earlier. One of the choices, in order to do the fibula pro tibia fixation, you obviously need to have appropriate soft tissues. And I think in our cohort we may have had certainly we didn't need to reoperate for any wound problems in the fixation group. In fact, I don't think there were any infections either. So with careful tissue handling, there is a bit of selection bias here, that the soft tissues were in a good state to start with. And so long as you practice safe soft tissue handling, again, it's not about the bones, it's about the soft tissues. That's what provides your healing afterwards. So long as you do that appropriately, then if they've got good enough soft tissues to do a plate in the first place, they shouldn't really get any wound problems afterwards. And historically, in a lot of the other papers that perhaps favour an intramedullary device as a more stable, less invasive, minimally invasive technique, if you like. That might be the case if that prohibits making a larger lateral incision, I guess. But you still have wound infections with those. And certainly even in our group of the ones that we looked at, there were actually more soft tissue complications in the nail group than there were in the open plating group.
Yes, I noticed that, and certainly that's been my own experience. Some technical questions, really. So when you were doing your lateral approach, obviously, as everyone will be aware, the fibula is, well, it's sort of more or less posterior, particularly as you become more proximal. And for trainees out there, were you able to use locking screws even on the more proximal end of the plate, or did the curve of the anterior bow of the tibia effectively make that difficult such that you went non-locking higher up? How did you go that? You managed to get your locking screws in all the way?
Absolutely. And the beauty of locking plates, again, there's lots of studies looking at the biomechanical advantage of locking plates versus non-locking plates. And we know that in sawbone models, as well as reality, that the structure created by a locking plate is much more because it's a locking plate, it acts more like an external fixator. So you don't actually need to have the plate absolutely opposed or contoured round the fibula. And I'm sure we've all been there where, depending on where the ridge is, it doesn't always fit perfectly. But with that locking ability, and certainly the plates that we used, you've got the ability to use either non-locking or locking screws in the same plate. So there was never any concern or problem with that.
Okay, that's good. That's helpful. Thank you. Of course, with the nail, and I'm afraid I share the view of your colleague that it is the work of Satan in no uncertain terms. For sure, it has a role. When you did do the nails, did you do any joint preparation with a view to formalizing fusion, or did you just sort of whack it up and hope for the best?
Really, really good question. So in none of these cases did we prepare the joints. And the reason being, again, these were really comorbid patients with poor soft tissues, probably anaesthetic nightmares that you just wanted to do the operation and get out of there. And in order to do the joint preparation, certainly in an open technique, it almost defeats the object of doing it in a less invasive way. In terms of if you were going to prepare the joints arthroscopically, which is obviously much more of a technique now, that depends on a certain skill level. And a lot of these patients done on a general trauma list by non-foot and ankle surgeons, for instance, which would just massively increase the time and surgical skill. So no, we didn't do any formal joint preparation. They were just for the fracture, which comes with its own problems, increasing the risk of non-union, getting the alignment, the technical skill of actually, it's not just as easy as whacking a nail up. We've seen lots of post-op x-rays where the nails missed the calcaneum altogether, and then you've got screw breakage and all those things. So it's technically much more challenging. It's not just a case of whacking it up and hope for the best.
Forgive my cynicism. And did you remove the nails subsequently, or did you leave them in?
So again, it was always something that we probably consented the patients that there was a possibility of that. And certainly in, I think almost 50% of our nail patients, they ended up having some or all of the metalwork taken out. One of the big things that they complained of was that feeling the nail, it being proud or prominent in the sole of their foot. And that's again just increasing the morbidity, another anaesthetic, another operation, pain, a stiff, not very well functioning ankle.
Yeah, absolutely. I think that's quite a common problem after this. Given, of course, it was surgeon selection, and obviously people with very poor lateral soft tissues, you elected not to put a plate on. What was there any comparison in the fracture configurations between the plate fixation group versus the nail? Are you dealing with the same types of fracture, or is it that the nail ones had higher complications because they inherently were worse to start with?
Yeah, no, I think there is a table that looks at those different factors, and one of those was fracture configuration. And I'm almost certain that was a similar group of supination, external rotation type fracture patterns. So I think the groups were comparable in that sense, although the numbers were different. Obviously, there was double the number of fibula pro tibia versus the nail side of things. I keep mentioning selection bias, apologies for myself, but that is one of the big flaws of the paper. I think that was mentioned. We looked at it's actually the Charleston Comorbidity Index, not the Charleston, which has actually been published, but this, if for anyone who's not familiar with it, is a calculation of 10-year mortality, depending on how many comorbidities you've got, and there's also an age adjustment in there. The comorbidities and the soft tissues and other things that went along with that were probably higher in that nail group. So they were possibly already destined to do worse. But when we did the multivariate analysis, taking out of the confounding variables, fixation type and age were the two things that were statistically significant, showing an increased risk of any complication or reoperation rate.
Okay, that makes sense. Question we sort of touched on earlier, but from Syed Ahmed Matwali. So we talked about how to target the tibia as you get more proximate. Do you have any tips on that as to how you targeted it?
Target as in not to miss the tibia, because that is actually a really, really relevant and good question, because again, we've seen lots of this, because as you rightly say, the fibula is posterior relative to the tibia when you're lying with the patient supine. I mean, in terms of a position, we would always kind of put some sort of support under the ipsilateral hip to try and rotate and internally rotate the leg. I think the important thing is understanding your anatomy in the first place, making sure you've got the fibula out to length and rotationally reduced, and appreciating that your trajectory and angle on a true mortise view and a lateral X-ray, and just being careful with your intraoperative imaging to make sure that you have gone through the tibia as well, and it's not gone through the back. And once you've got one in a nice plane, you can use that as a reference to the others anyway.
Yeah, so to some extent, it's feel as you go, isn't it, that you're in bone, but that kind of comes with experience. But
yeah, and the other thing, just as a technical tip as well, it's funny because we've seen all sorts of fibula pro tibia fixation in terms of the number of screws, how many cortices, how far above and below the syndesmosis you need to go. The only thing that defines fibula pro tibia fixation is 2 or more screws going from the fibula into the tibia, one of which must be above the level of the incisura. So commonly we would use 3 or 4 screws, usually at least 3 cortices, if not 4 cortices across. But we've seen it where people have put in like 6, 7 or 8 screws. I'm not sure that's necessary. I think you're going to get just as rigid and robust fixation with 3 or 4 screws, making it a fixed angle locked device.
Yes, I would think so. Interestingly, you use 3 and 4 cortices. I've always thought 4 because of the rest can be mush in between, but you use 3 as well.
It's a locking plate, absolutely, because you've got your cortical fixation, but you've got your locking into the plate as well. I think, if you get 4 cortices, that's absolutely fine. If it falls a bit short, it's not a massive problem. We've not seen that, but what we have seen is obviously, the lots of soft tissue swelling to start with. In the 2 patients that needed some screw removal in the plating group, it was because they had prominence of the screws, and it wasn't on the lateral side, it was on the medial side where they poked through.
Yes, I mean, presumably the idea is not to have it a couple of inches proud, but yeah.
The javelin all the way through, no.
Yeah, okay, very, very good. Moving on, obviously one of the points of this study was early mobilization, getting people going. What actually was is your post-operative protocol for these patients now?
Yeah, another great question, which I think has probably changed over the years as well, just due to sort of observational experience, really. The whole point of these is to get them up and mobilizing on day 1 after the surgery. So there's no point putting them in a back slab for 2 weeks and saying non-weight bear them. The whole point is that the majority of these patients aren't going to be able to non-weight bear. It's really difficult to non-weight bear. You're trying to create a stable enough construct that they can weight bear, not immediately, and obviously they need protecting. So we tend to probably put them in a back slab in theatre, but then the next day they'll have their cast changed to a full weight bearing cast, and they just get going straight away with physio, etc. We went through a period of saying, well, why don't we just stick them in a boot? straight from theatre, saves all messing about with plaster. But what we found was, again, because of the associated significant soft tissue swelling, as that was going up and down in the boot, they started getting soft tissue problems, shearing, and we did get some wound breakdown. Not in this patient group, but we have had it. So we've gone back to having a walking cast. It means they can't pick at the scars. It's just better, and that's what we do. So we put them in a walking cast from day one, get them up with physio, wound check at a couple of weeks. And again, depending on the individual, the soft tissue condition, we'd ideally put them in a boot at 2 weeks when we know the wounds have healed, so that they then can start getting early range of motion, but still protected weight bearing. And obviously the diabetics are a different group altogether. We'd probably total contact cast them until we're happy that everything's settling down.
Sure. So, and in your non-diabetics, with the hindfoot nails, was that the same protocol, or did you do something different with those?
We tended to, still protect them for a couple of weeks in a plaster, but again, get them up and weight bear on day one if possible. And again, that's easier said than done. Even if you've done a fantastic surgical job and you know it's stable as anything, getting them out of bed is a different matter. But as long as you know you've done what you can, that their leg will take their weight. It's all those other comorbidities that need to be optimized to get them out. But from the surgical perspective, we feel it's pretty safe to get them up and weight bearing. And it's probably safer to do that than try and get them to non-weight bear, because that's when they fall over and break the hip on the other side.
Yes, which would be most careless. We're running towards the end of this section, but a final question really, which is, in the light of this study, what is your current management protocol for these, unstable fractures in people over 60? Do you have any sort of guidelines or protocol on who gets a lateral plate for fibular pro-tibia fixation, who gets a nail? Is it still surgeon preference, or what's the current practice in Sheffield?
So very much patient selection, and our first choice is absolutely plate fixation every single time. We discuss obviously all the cases in our trauma conference, and if the surgeon, depending on who's doing the operating, pretty much all of our trauma patients who are on the colleagues who do general trauma lists are happy to do this type of fixation. If it's slightly more complex, we'll come in and help out. Very, very rarely does someone get a hindfoot nail. We do still do them, absolutely, and we're not saying you can't use them. They absolutely still have a role and a place to play, but they are for the very, very few minority where soft tissues absolutely preclude anything more than a small cut, really.
Okay, well, Carolyn, thank you very much. I think there's no more questions from the virtual floor, so we'll move on to the second half in a moment. Please feel free to stick around and join us for further discussion later if you'd like to, but thank you very much for sharing your thoughts with us this evening. So I'll hand over now to my colleague, Nijil Vasukutty, to take the second half of the session and lead us into the second paper. Nijil.
Thank you, James. Good evening, all. So we're moving to the second half, the second paper. This is a paper from the 2024 Bone and Joint Journal. It's a pragmatic RCT looking at early motion and directed exercise following ankle fracture fixation versus immobilization. We've got Ben Lau, who's STA training from Guy's and St. Thomas. He will present a short précis of the paper. After that, we've got Professor Benjamin Ollivere, who does not need any introduction in any orthopedic gathering. So he's a senior author, so he will be on this. He's already online. He will present his reflections and the background to the study. Professor Ben Ollivere, he's a professor of orthopedic surgery in University of Nottingham, and he's also the associate pro vice chancellor. He's got an extensive research portfolio and holds a large research grant portfolio. His clinical interests are mainly around major trauma, bone infection, and managing trauma complications. So let's listen to Ben Lau presenting a short précis of the paper first, and then we'll go on to a discussion. Over to you, Ben.
Hello, My name is Ben Lau. I'm an ST8 trainee at Guy's and St Thomas's Hospital. And first off, I'd like to thank BOFAS for inviting me to participate in the Virtual Journal Club. And today I'll be presenting on the early motion and directed exercise, the EMADE trial, a pragmatic randomised controlled trial by Paul Matthews and the team at Nottingham University Hospitals. So ankle fractures make up around 14% of all orthopaedic admissions in the UK. And traditionally, patients after open reduction and internal fixation were placed into a cast and kept non-weight bearing for 6 weeks. The problem with this is that this often led to stiffness, persistent swelling, muscle wasting, and a delayed recovery. Over the last decade, there's been growing interest in early weight bearing and motion to promote faster recovery. However, many prior studies mixed early exercise with early weight bearing, making it difficult to isolate the effect of motion and exercise alone. This is where the EMADE trial was designed to specifically test the role of early progressive exercises without early weight bearing. So the study aims were to compare early motion and structured exercise with traditional 6-week immobilization after open reduction internal fixation for Weber B ankle fractures. This means AO 44, B1, B2 or B3. Patients aged 18 or over with closed stable Weber B ankle fractures treated with open reduction internal fixation were eligible, including those with syndesmosis stabilization. Everyone was initially non-weight bearing in a below knee cast for the first 2 weeks after surgery. Exclusions included anyone with diabetes on medication, pre-existing ankle arthritis, steroid use, open wounds or ulcers, neurological conditions, or any post-operative complications like infection or wound dehiscence at the 2-week appointment. Patients also had to be able to attend weekly visits and complete study paperwork in English. At the 2-week post-operative clinic, eligible patients were recruited and randomised into 2 groups. The EMADE group received a removable boot or cast that allowed early exercises while still non-weight bearing for the next 4 weeks. They were asked to complete range of motion and strengthening exercises 3 times a day at home, supported by weekly physiotherapy sessions between weeks 3 and 5. These sessions included exercise progression, advice on healing and swelling, and reinforcement of self-management. The focus was on empowering patients to take an active role in their recovery. The immobilization group, by contrast, received a new lightweight below knee cast for 4 more weeks, continuing full immobilization and non-weight bearing. The primary outcome was the Ollerud-Molander ankle score, the OMAS, at 12 weeks, which is 6 weeks after the intervention ended. Secondary outcomes include OMAS at other time points, the EQ5D5L for quality of life, and the A-form, which measures ankle pain, function, and overall well-being. To detect a 10-point difference in the OMAS score, which is considered clinically meaningful, the study required 60 participants per group for 80% power, allowing for attrition, targeting a total population of 156 participants. In total, 331 patients met the inclusion criteria. Of these, 69 patients, around 20%, declined to participate. A further 105 patients, roughly 32%, were excluded for medical or other reasons. This left around 157 patients, just under half of those screened, who were randomised into EMADE and immobilization groups. Baseline demographics such as age, gender, BMI and smoking status were all well balanced between the groups. Out of the 157 participants recruited, 130 completed the 12-week follow-up, giving an 83% data return rate. So this is quite a busy results slide, and highlighted in the red boxes are the results at 12 weeks. You can see the EMADE group showed a 13.2 improvement in the OMAS score compared to the immobilization group. This exceeds the minimum clinical important difference of 10 points, confirming a meaningful functional benefit. These improvements seem to persist up to week 24, but by 1 year the groups seem to converge. Similar improvements at 12 weeks can be seen in the A-form and the AQ5D5L. These differences become apparent after the immobilization period ended, suggesting that early motion accelerated recovery once normal movement had resumed. So this is a graph to represent the OMAS score over time, and you can see that at week 6 there is no statistical difference between the 2 groups. However, at week 12, both groups improved, but the EMADE made a faster recovery. with a 13.2 point difference between the two groups, which was statistically significant. These differences are still maintained at week 24 with a 12.5 point advantage in the EMAID group. However, as mentioned by week 52, these outcomes seem to have converged and the scoring has no statistical difference between the two groups. Upon subgroup analysis of the trimalleolar fractures, they found an even stronger effect. In this subgroup, the EMAID group scored 20.7 points higher on the OMAS score compared with the Mobilisation group, which is statistically significant. Although the numbers were low, it may suggest that more complex fracture patterns may gain the greatest advantage from early structured motion. From a safety perspective, there was one deep infection in each group, both of which occurred well after the intervention phase and was unrelated to the study protocol. There were no cases of malunion, hardware failure, or instability. So what does it cost? For the main added cost for the EMAID was the physiotherapist's time. That's about £96 per patient, equivalent to 1.75 hours in total. There were deemed to be no additional costs for boots or casts. And when this was modelled, this was around £7.20 per OMAS point gained and around £72 for the 10-point improvement. The cost per quali gained was around £1,700, which is well below the NHS threshold, showing that EMAID can be highly cost effective. In summary, EMAID led to a faster and clinically meaningful functional recovery compared to traditional immobilisation alone after Weber B ankle fracture fixation. It supports the safety and practicality of introducing structured motion from 2 weeks post-op without compromising fixation stability or increasing complications. Although long-term outcomes eventually are equalised, the early recovery gains are valuable for patients' quality of life and function. There were many strengths to this study. It was a robust study design with clear methodology, block randomisation, and stratification for syndesmosis fixation, which reduced allocation bias. There was a well-defined homogeneous population with enhanced internal validity by excluding confounding factors. It was a clinically relevant and focused research question, and it uniquely tested the effects of early progressive exercise alone without early weight bearing. There was comprehensive outcome assessment with multiple validated PROMs, and safety and cost effectiveness was also evaluated. There are some limitations to the study as acknowledged by the authors. There may be limited external validity as recruitment was from only 2 UK centres, with most participants from a single unit. Only Weber B ankle fractures were included, which may limit the applicability to more complex or unstable injuries and excludes high-risk patients. And although this was useful to establish motion alone and the effects of it, the non-weight bearing protocol means that the results have limited generalizability, as it does not necessarily represent modern practice. There is some potential selection and compliance bias. 53% of the screened patients were excluded and 21% declined to participate, so it may overestimate the benefits in the real-world setting where adherence varies. There is a small subgroup analysis. In the trimalleolar subgroup, it probably wasn't powered for definitive conclusions despite the large observed benefit. And as attrition increased over time, the later time points may be slightly underpowered to draw full conclusions. So, the take-home message: the early motion and directed exercise program based on early progressive exercise with patient-centered support may provide an accelerated recovery after Weber B ankle fracture fixation compared to a traditional cast immobilization alone. Commencing ankle exercises at 2 weeks post-surgery appears to be safe and effective. Thank you for listening. Hello.
Great. Thank you, Ben. So we got Professor Ollivere here to give his sort of reflections and thoughts on the paper. Thank you for joining us, Prof. First of all, what was the background to designing and carrying out this study?
Yeah, thank you for asking me to talk about this paper. This is a bit of a personal journey, this paper. So this is the first randomized trial I ever did, but not the first that I ever published. So I got the funding for this and the idea and the protocol when I was still a trainee. And the intention was to undertake this RCT on fellowship. I did my fellowship in Nottingham. Now, what happened, of course, is that it was a much bigger task than I'd expected. All my research prior to that had been kind of translational stuff, ex vivo work. I'd never done a clinical trial, so there's definitely things that I would change about this. But we secured the funding in I'm trying to think 2011, but didn't actually start the trial until ethics was approved in 2014, and we started recruiting in 2016 and recruited until through to 2018. So that tells you the kind of time frame was going on, and the background thoughts really were around the concept that at the time, and things have changed slightly, pretty much every other major common injury that you can fix stably was moved early, and yet in common practice in the UK that was not happening. People weren't weight bearing in 2011, and they certainly weren't taking plasters off and doing early recovery. And that was really predicated by a couple of papers from Northern Europe that were small randomized trials, smaller than this one, that had shown a high early infection rate. And I'm sure people are aware of that. You know, if you're from my kind of generation, the teaching was you would wrap the patient up in plaster till the wound was healed, then you take it off, and the physiotherapist would battle with the stiffness that had accumulated after that. So I kind of thought to myself, well, you know, if we're fixing things stably, why not just take off the plaster and get them moving? And the logic behind the protocols, we would wait until the 2-week wound check to reduce the risk of complications associated with early weight bearing. And what happened in the meantime was that NICE issued some guidance, actually really without evidence at the time, based on Bob Handley's views, which were good views, that you should weight bear ankle fractures. So we got this trial already going, recruiting patients, and standard of care had changed, which is part of the reason, you know, the speaker picked up that, you know, this was designed originally as kind of 5-center RCT, but we then had the issue that standard of care had changed, and in those centers that we hadn't already started recruiting from, we had to cease. And that's one of the problems that you know, you do get with these things when protocols change. So if I was doing it again, I definitely would have it as a weight bearing trial. I think that's not unreasonable. But I think it is interesting insofar as, you know, those of us treat a lot of complex foot and ankle injuries, which I do really rely on our therapists. You know, we rely on our therapists more than the evidence would suggest. And this was undertaken, my first PhD student actually was a physiotherapist, did the trial in the end. And it was about understanding the value of controlled therapy or not, because there's quite a lot of very, very pragmatic trials. And this is a pragmatic trial, but it's more on the kind of on the efficacy than the effectiveness end of it. So, you know, we are controlling quite tightly the interventions given here. It's an intervention given in a directed way. It's an intervention that had quite a lot of work behind it from physiotherapists from various centres to secure buy-in from the centres that were going to be recruiting patients, and also a fair bit of patient input into what they were prepared to do. And if you kind of read the paper, you'll realise they get 3 face-to-face physio appointments, and they also get a bunch of progressive exercises they do at home. And the intention really was to start them early with tone and conditioning exercise. Your presenter put the nail on the head, you know, and the intention was to start their therapy running rather than starting their therapy from 6 weeks of mobilization and a whole load of muscle loss, volume loss, and tone loss and proprioceptive loss. I think from where we are now, you know, the evidence for weight bearing is good, but most of the weight bearing trials don't do early motion. Most of them don't have high quality therapy associated with it. And curiously, their effect sizes are much smaller than this, which begs the question, is early weight bearing actually just poor therapy? Is it just stopping the conditioning in your quads particularly, but not in your perineals and not in your tibia, not in the other muscles that you need to fire to control your foot and ankle? It definitely has an effect on proprioception. So yeah, I guess the next thing for me, and I do much bigger trials with much bigger things, and at some point we will probably put this in to do a proper RCT, you know, across the country with weight bearing as well, and maybe factorial design. So with a factorial design trial, you can test 2 potentially interacting effects. So you can test the benefit of weight bearing and the benefit of mobilization. So yeah, that's kind of, I suppose that's my reflection. It's a long, I never thought it was actually going to ever get published, because it sort of started a long time ago and then it kind of finished, and eventually we had something that was good enough to publish. So it's delightful to see it in print.
Yeah. It's interesting that you brought up that weight bearing point, because the BOFAS guideline came out, when was it, 15, 16, or somewhere after you started recruiting, is that correct? Because then they started stressing on early weight bearing. So that's sort of do you think that sort of put you open for criticism, because there was some
Yeah,
lectures
yeah, it
in the
absolutely did. Absolutely did, and you know, it has put us open for criticism because the standard of care has changed during the period of the trial, and that is so interestingly, had it been a negative trial, then it probably would have been no value because you don't know in the context where you are. But what you can say is that there is a benefit to early mobilization. There's benefit to direct therapy. How that interacts with weight bearing, you can't tell from this. You can't say whether or not weight bearing is more important, less important, whether the effects will be additive. What you can say is that a key part of this is high quality therapy and patient engagement with their treatment. And yeah, if you look at the effect sizes, mobilization seems to be bigger than weight bearing. There's a lot of isolated weight bearing trials out there, and they do show a benefit, but it's a small benefit.
Yeah. I mean, again, another point, I was looking at your email protocol. So it's quite intense between the week 2 and week 6, and necessitating weekly follow-ups.
Yep.
So if you compare that to a push for less and less face-to-face appointments and more virtual appointments and quick discharge and all
Yep.
that. So where does that fit in? I mean, how would you sell that to your manager? Bring your patient in weekly to your physios from week 2 to week 6?
Again, the world has changed, hasn't it? The question is, do you need face-to-face physio? Well, you definitely need to be seen for if you're going to do early mobilization, you've got to see the wound, you know, because we know that if you're starting to mobilize wounds that are likely to dehiss, you get a much higher complication rate. If you are talking about the health economics, it's again about the willingness to pay. So, you know, NICE would say that anything that is 20,000 or between 20,000 and 30,000 pounds per year for one quali is value for money. This is, you know, less than 2,000 pounds a year for one quali, so it is value for money. The question is where does that fit in? So from a societal willingness to pay, it does fit in. So, you know, from the taxpayer's perspective, it is value to get working people up and going, non-working people reliant less on their support structures. But the difficulty we have in this country, of course, is that the hospital pays for society's benefit, and that's where there are difficulties. We're fortunate still to have in fracture clinic joint face-to-face physio in our unit, and so we tried to decommission it, but it wasn't decommissioned. So we're able to see patients with our physios at any point, and they get the physio the time we refer them, rather than going to the community, which is sort of an unusual setup. Would this be reasonable to do with a virtual appointment? Yes. Do you need to have all of the face-to-face appointments? Probably not. You know, remember that the trials before this, both of them had shown high rates of adverse complications. So, you know, the reason the patients were seen face-to-face really was for that wound inspection, to ensure there was no dehiscence, to ensure there was no infection setting in. I think it was a Danish study originally. They're not in this paper because they're from some time ago, but they showed something like a 15% complication rate with early mobilization, but they were starting at day 7. Hence the delay to day 14, and we also excluded medicating diabetics for obvious reasons. So I think probably, being honest about it, the face-to-face is probably not required. It's more safety, and what you do in a trial is slightly different to what you would do outside of a trial window. But it's a valid point, and we also have the issues with that may affect the decline to participate. So again, if you look at large trials, and this is a medium-sized trial, recruitment of 50% of your eligible or your potentially screened patients is not bad, but there is a relatively high decline to participate rate at about 20% of the overall population. It's probably to do with the burden of the intervention rather than anything else. We don't know, but that's probably the reason. And if it were not face-to-face physio, if it was virtual physio, as we do for a lot of our patients now, I think probably you'd be in a higher adopting rate, but you can't tell that from this study. It's you know, a conjecture rather than something we've looked at.
Absolutely. Our audience seems to have gone a bit quiet, so can I remind everyone to put any questions or comments you have in the Q&A box?
Oh, come on. BOFAS is renowned for kicking trauma surgeons, you know, investigating stuff in the foot and ankle. So I'm expecting a whole load of, oh my goodness, you know, how did you do these poor fixations? Why were you doing this? Why were you doing that? In my hands, the patients do much better, all that kind of stuff. So maybe we got it right this time. Who knows?
Yeah. Prof, another question. You know, patients that need like a sort of semi-planned repeat procedure. So for surgeons that routinely remove syndesmosis screws, for example.
Yeah.
So if they need syndesmotic screw removal, say at 3 months. So
Yeah.
where does that subgroup fit in that recovery chart?
Yeah, so that's a really interesting question. Our protocol in Nottingham, there are at the time this was done, there were 12 surgeons doing acute trauma, which is a relatively small number for the size of the unit. We're up to 16 now. We have had a fairly tight approach to how we do our post-operative management. We share patients, we operate on each other's patients, and so for some time we have not removed syndesmosis screws unless they're symptomatic. And I can't remember off the top of my head, but I think there were one or two patients ended up with planned secondary procedures. There's a relatively small number of syndesmosis screws in this cohort because obviously they're VB fractures, and so many of them didn't require a syndesmosis screw. I'm just trying to look, see if I've got a number as to how many had a syndesmosis screw, but a small number, a handful.
Okay. Sorry, did you say you're looking at something?
No, I said I can't remember. I can't remember exactly how many patients had syndesmosis screws, but it was a handful, and I think we had 2 planned reoperations for symptomatic metalwork. And because this is a pragmatic study, you accept that that's part of their treatment pathway, and you don't adjust for it, and you don't do an as treated analysis. We had only 1 patient in each arm that didn't receive their allocated intervention. And one of those was I can leave you to make your own conclusions, but they removed their plaster and never seen again. So how they're doing, we don't know, but they're somewhere.
Yeah, obviously, you're so much into research and you've come out with this nice study, you published it. How much have you managed to convince your foot and ankle colleagues, or trauma colleagues in Nottingham, or have you managed to change their practice? What are they doing?
Yeah, so mixed, I think. I mean, I think the reality is that many of us believe that what we do is right, or we wouldn't do it. That's how it is. We all have the things that we've been taught. We have things that we have evolved, and we have things that are kind of unique to us. And the biggest drive of all of our
I was saying there's a bit of that orthopedic ego as well, isn't it?
There is. And the biggest driver of all our practice is complications, right? The thing that makes it's the one patient that you treat where they get an infection, you never do that treatment again. And thankfully we didn't have many complications in this group. So my colleagues are happy to early mobilize. How many do? I honestly don't know. There is a protocol for it. I do. I think a number do. But it's not ubiquitous in our practice, partly for the physio reasons. When I paid a physio to do this intervention as part of the trial, that was the reality, was that the trial funded a physiotherapist. We don't have any additional physiotherapy. So I suspect the answer, if we were to go back and audit our results, which maybe we should, would be that it's now selected. So it's used for patients where we really think they would benefit, and we know it's safe to do so.
Good, excellent. Looks like we do not have any questions from the floor. Thank you very much for a fantastic session, and thank you, Ben Lau, for your presentation. So we're coming close to 9 o'clock. Dinner is possibly going cold. We'll get James has come in as well.
Okay, well, thank you very much, guys, and thank you, Ben. I have to just a couple of comments, really. The first thing is that I would imagine that a patient who takes his own plaster off and disappears out of the wide blue yonder is the politician's absolutely favourite type of patient to be encouraged in this day and age, because we count them all as excellent outcomes because they haven't initiated PIFU, so they must be fine.
We did have some feedback from him, actually, James, which is funny, and I'll share it with you because it's late in the evening. So we text is one of the ways that we follow up, and the text went out, and this particular patient, the text came back. This is his soon-to-be ex-wife. If you find where that fucker is, let me know, because he's left me and the children. Frankly, I didn't know what to do with that. I wasn't sure whether that was a good result or a bad result, so we excluded him from the trial.
I think that depends on who you ask, really, the viewpoint. He may count that as brilliant. Probably harsh on the family.
She was probably better off without him, but I never met her, so I don't know.
Well, thank you for sharing that. And the only other comment I have to make is I've no idea what Nijil's talking about, this orthopedic ego, because I just know that I'm always right, of course. But
Really? And in your hands, it all does better, right? I mean, same as mine.
Of course, inevitably. Right, well, Ben, thank you very much for sharing your thoughts this evening, and Carolyn also, as our other senior author, thank you very much for joining us. A big thank you to Claire and to Ben for the presentations, and of course to our IT colleagues, Nijil for presenting, and our IT colleagues Ben Lau and May Labidi, who is bowing out after such a long time. May, thank you very much for all your work over the years. This is the final Journal Club for 2025. I think we'll resume in January. Obviously, we've got BOFAS at the end of November coming up. So, well, I hope to see you all there. And thank you for joining us this evening. You should get your link for your certificate once you shut down from the webinar. Thank you all very much. Bye bye now.
Thank you all. Thanks, James.
Thanks, James.